Much of what we've done so far in researching cancer in general, but lymphoma specifically, has focused on the cancer cell, which in lymphoma is a B cell, kind of a B lymphocyte. But there's increasing evidence, and this is what the focus of our discussion today was, on the microenvironment. Those are other cells that are around the cancer cell that support its growth. That includes T cells, some monocytes and macrophages, as well as stromal cells. All of these are kind of normal components of the lymph node, but in this case, rather than doing something good and suppressing the cancer, they're actually providing assistance and help. And the cancerous cells themselves are no help in that they then will suppress the microenvironment by kind of getting regulatory elements. These are cells that usually damp down your immune system, bringing them into play and actually increasing the whole kind of regulation of the environment. There are a number of new treatments that are looking at doing one of two things: either removing this suppressive elements and these cells that are suppressing the microenvironment, or secondly, activating immune cells. And there are a number of treatments. There's an anti-PD-1 antibody that has shown a lot of promise, and data has been presented at this meeting. There is an anti-CTLA-4 antibody known as ipilimumab in combination with PD-1 shown at this meeting, with a lot of activity in melanoma and in other diseases. And the same thing is true also in blood-related cancers. And so the microenvironment and the role of the immune system is becoming increasingly important. I think that really is that exciting. I think that in times gone by, melanoma was a disease with very few treatment options, and that has dramatically changed with ipilimumab and now with the anti-PD-1 antibody, and the two used in combination. The results are very promising, and I think again this is a new and exciting golden era, if you like, for treatment in melanoma. Treatment also is being expanded now into other diseases, and similar results are being seen, and that's again very exciting. ALK, as in the ALK positive cells that are present in tumor cells. Yeah, so I think again there's been a lot of promise with directly inhibiting ALK and showing that that actually has a significant effect on the cancer cells. That's true in certain solid tumors, but also true now in certain kind of lymphomas. So I think again a very specific therapy. That counterbalances the conversation about the microenvironment, where ALK is very specific within the tumor cell, and the microenvironment is obviously the cells around the tumor cells. So I think future therapies are going to be combinations of the two, where we target the cancer cell and target the microenvironment all at the same time. I think again this is something that's very rapidly going to translate into practice. Ipilimumab, the anti-CTLA-4 antibody, is already commercially available and being used in melanoma. My prediction is that combinations with that and other checkpoint inhibitors are very soon going to be available for patients. And so I think this is a space that physicians should pay attention to, because in combination with other standard approaches, this may well be the future of treatment for these patients. Equally, there have been very exciting results seen in other cancers, lung cancer with the anti-PD-1 antibody. There are now trials ongoing in Hodgkin lymphoma and non-Hodgkin lymphoma with the PD-1 antibody, with a lot of exciting results. So I think the future looks very bright for checkpoint inhibitors in general, and immunological approaches as well.